Here I am, Dr. Debbie, back for some more talking about the kidneys. And we have reached the tubules, which is where the action happens. So I've already said that we are filtering into the urinary space about 180 liters a day of fluids. And there's no way that we could survive without reabsorbing most of that fluid and other things that are in it. So that starts immediately after the Bowman's capsule, that urinary space at the glomerulus, in a structure called the proximal convoluted tubule. So as we move along, we're going to go through different parts of this tubule, and we start at the proximal tubule. All of the tubules have similar anatomy. There are capillaries wrapped around them, and if you remember, capillaries are a single layer of cells with a basement membrane. And here we have the capillary. There are red cells in the capillary. The endothelial cells here are not fenestrated, and they have tight junctions, and surrounding the whole thing is something called a basement membrane. Similarly, the endothelial cells that line the tubules are a single layer with tight junctions. They are tightly bound together, and they have a basement membrane as well. And there are a few cells in the interstitium that are providing structure and also just space around which fluid can flow. The single layer of basement membrane is along what is called the basal or basilar layer surface of the epithelial cells. So the epithelial cells have a base and an apex. A base and an apex. So this is the basilar level layer. This is the apical layer. And the apical surface is within that urinary space. It's in the lumen of the tubule, and it's in contact with filtrate. And it has villi, so it has a huge surface area, and it has cilia, which help to move fluid along with pressures through the tubule. Now, there are real differences in the plasma membrane on the basilar surface than on the apical surface. And we're going to start by talking about the basilar surface. There are a lot of ion pumps at the basilar surface. Let's go back for a second here. At this surface, in contact with the extracellular fluid adjacent to the capillary. And the primary of those ion pumps is the sodium potassium ATPase. And you remember this pump. This is the same pump we've talked about several times. The sodium potassium ATPase is using energy. It's using ATP, and using that energy, it pumps 3 sodium cells out of the cell, 3 sodium ions out of the cell, in exchange for 2 potassium ions that come into the tubular epithelial cell. And this is always against a concentration gradient, because the extracellular fluid has a lot of sodium, but we're adding more sodium. And the intracellular fluid has a lot of potassium, but we're adding more potassium. Because of the amount of energy that this is using, ATP being converted to ADP, it requires lots of oxygen. And so we have 2 important things. We have to have a lot of mitochondria in these cells to be constantly making our ATP and providing the energy, and we have to have really good levels of oxygen, which means good blood flow. Kidneys get easily damaged in conditions where there is low blood flow and or low oxygen. Low blood flow means low oxygen because the oxygen gets used very quickly. So low flow damages kidneys, low oxygen damages kidneys. On the apical surface are different things, okay? And they, by and large, are co-transporters. So there is a transporter, particularly in the proximal convoluted tubule, that moves sodium and glucose. There is quite a lot of sodium in the lumen. The filtrate contains glucose, and this concentration of high sodium in the lumen can help to move glucose into the cell down the concentration gradient of sodium. And this is what we would call secondary active transport. The reason there's a lot of sodium in the lumen is that there's a lot of sodium in extracellular fluid because of the constant action of the sodium-potassium ATPase. There is also a sodium and potassium and chloride cotransporter. I've got my charges wrong there. It should be Na plus, K plus, Cl minus. And this is a cotransporter that we'll see at the apical surface of the tubule somewhat later as we move along through the tubule. But this particular cotransporter uses sodium to drive sodium and potassium and chloride down the concentration gradient of sodium from the lumen and into the tubular epithelial cell. So it's 1 sodium, 1 potassium, and 2 chlorides, and this is called the triple transporter, and we'll talk more about that in a little while. There are also counter transport mechanisms. So there is a sodium hydrogen ion counter transport that trades a sodium ion into the cell for a hydrogen ion out of the cell into the lumen. Again, this is at the apical surface. And this is one of the mechanisms that is used to help us manage our pH, our acid-base balance, that we can get rid of hydrogen ions in the kidneys. And again, this happens at certain points along the tubular epithelial cells. The kidney is incredibly complex and interesting in that these tubular epithelial cells, which have the function of reabsorbing and of creating homeostasis and balance in a number of ways, at different points along the lumen, the apical surface has different co-transporters and counter-transporters, and different tasks are done at different parts of the nephron. And again, because this is using the gradient of sodium, it is an indirect secondary active transport using the sodium concentration that has been established throughout the organism by the sodium-potassium ATPase. There is a little bit of protein and amino acids that makes it across the fenestrated capillaries and podocytes and basement membrane into the filtrate, and it is almost entirely reabsorbed by pinocytosis. It's kind of just picked up and eaten by those cells as it comes into contact with the villi, and then excreted out of the tubular epithelium cell and back into the capillary. So after the first bit of the tubule, there is no protein in the filtrate. This is just a diagram showing you some of those mechanisms. So here we have our capillary, we have our interstitial space, which is mainly filled with interstitial fluid, a few stromal cells, and we have the constant operation all along this basilar cell membrane of the sodium and potassium ATPase. 3 sodiums out, 2 potassiums in. And so this is establishing this gradient of high sodium outside the cell and high potassium inside the cell. Along the lumen of the tubule, and here we're in the proximal tubule, we can see some of these transporters. Here we have the sodium hydrogen ion counter transport. So we're exchanging a sodium ion down its concentration gradient for a hydrogen ion. There are other counter transports. Here we have one that uses sodium and chloride down the concentration gradient with hydrogen ion out. Here we have one that is using calcium and sodium. Here we have one that is helping to transport amino acids. Here we have one that's moving glucose and sodium down the concentration gradient of sodium. And here we have one that's moving phosphate. Here we have magnesium going through a channel, and we have water diffusing all the time. All right. The main things that I'm concerned about in the proximal tubule are there is some exchange of hydrogen ions for sodium. The big one here is this glucose cotransporter, where glucose and sodium are together being transferred across the cell membrane down the concentration gradient of sodium. You see, with all of these secondary active transporters that use sodium, the sodium ends up then getting pumped back out, and it's by the action of the sodium potassium ATPase. We'll come back to some of the things that happen at that part of the tubule, but I do want to talk about acute kidney injury because this is important clinically. Whenever something interrupts the blood flow to the kidney, or something happens to cause direct damage to the kidney that keeps it from being able to filter or reabsorb, or when there's obstruction to the outflow of urine, any of those things can cause acute kidney injury. And each of those things has its own name. When we have an interruption of blood flow to the kidney causing kidney injury, we call that prerenal. And examples of prerenal kidney injury can occur from acute blood loss, from dehydration, from congestive heart failure where the pump isn't working properly. You could have a blood clot in the renal artery. There are a lot of things that can prevent oxygenated blood from flowing freely into the kidney and powering all of those things that the kidney needs to do. And whenever that happens and the kidneys quit functioning properly, that is called prerenal. Things that directly damage the kidney, things like post-streptococcal glomerulonephritis, which is an infection-triggered autoimmune problem in which the kidney tissues become inflamed and we lose nephrons. That is a renal problem or an intrarenal problem. Certain toxins, there are drugs that are quite renal toxic, and those drugs and some mushrooms that are renal toxic. So toxins can cause a renal be a renal cause of acute kidney injury. And then finally, obstruction can cause postrenal injury. So what do I mean by that? Suppose a ureter is obstructed by a large kidney stone and the pressures back up so that there is no longer the ability of the fluid, the filtrate, first to filter because that pressure can back up all the way to the nephron, but because it's not filtering and not flowing, we're not able to do the things the kidneys do, and that will cause acute kidney injury that's post-renal. Other things that can cause obstruction include tumors, prostate enlargement, sometimes trauma. And in addition to the pumps I showed you, there are other pumps. And the one we'll come back to a little later is the calcium magnesium ATPase. Although I think we'll also probably talk about the hydrogen ion potassium ATPase. What gets reabsorbed in the proximal tubule? Well, there are a couple things that have to be reabsorbed in the proximal tubule. And sodium is a big thing that is getting reabsorbed in the proximal tubule. And you could see that it is in many cases reabsorbed along with other things like glucose and amino acids. So there's a lot of sodium reabsorbed in the proximal tubule, and water moves with sodium in this case. If the sodium is reabsorbed, the water is reabsorbed, and the osmolarity doesn't change. So the osmolarity now in the filtrate is the same as it is in plasma. It's about 300. The osmolarity in the intracellular fluid of the tubular epithelial cell is at 300. The osmolarity of the extracellular fluid outside between the tubular epithelial cell basement membrane and the capillary basement membrane is at 300. The plasma osmolarity is at 300, or osmolality. I changed it some places. I haven't changed it anywhere, and my mouth tends to like to say osmolarity, but essentially the same, right? So by the time the filtrate reaches the end of the proximal convoluted tubule, convoluted just means it's twisty in shape, everything here is reabsorbed: glucose, proteins, amino acids. So by the time that filtrate gets to the loop of Henle, there is no more glucose. And this is important clinically because if there is glucose in the filtrate beyond the proximal tubule, it's going to stay in the filtrate. And it's going to not be reabsorbed, so it's going to over time affect the osmolarity of the filtrate, and it's going to end up being peed out. Now, why would we not be able to reabsorb all the glucose? Well, if there's a lot of glucose in the filtrate, say in somebody with diabetes with a blood sugar of 200 or 250, there are only so many cotransporters, and you can saturate the cotransporters in the proximal convoluted tubule, and if you can't reabsorb all the glucose, it's going to make it to the loop of Henle. But under normal circumstances, it is all reabsorbed before it gets to the loop of Henle. As we move through our discussion of the kidney, we're going to talk about diuretics, which are drugs that make you pee more, right? Diuretics are drugs that promote urination. And most diuretics obviously work in the kidneys because that's where the pee is made, or at least primarily in the kidneys. Many of them have actions in other places as well. But in the proximal convoluted tubule, this is where a kind of diuretic called a carbonic anhydrase inhibitor works. And two examples of carbonic anhydrase inhibitors are acetazolamide and dorzolamide. Acetazolamide is the older drug, the one that you're more likely to hear about. But both of them have the action of inhibiting the enzyme carbonic anhydrase in the proximal convoluted tubule. When there is carbonic anhydrase in the tubular epithelial cell along that apical border, and if you are inhibiting that, you don't create many hydrogen ions, and because remember that reaction between carbon dioxide and water is facilitated by carbonic anhydrase. So you still get a few, but you don't get a lot. And this slows down that sodium hydrogen ion countertransport. And so instead of putting hydrogen ions into the lumen and bringing sodium out, this is one of the ways that sodium is reabsorbed, a big way that sodium is reabsorbed in the proximal convoluted tubule. If you're not reabsorbing the sodium, then you keep the sodium and the water in the urine, and the volume of urine will be higher. We have now passed the proximal convoluted tubule. I want to just quickly review that in the proximal convoluted tubule, all of the amino acids and proteins are quickly reabsorbed. Lots of sodium and water are reabsorbed, much of it through indirect secondary active transport of sodium down its concentration gradient, through things like the sodium hydrogen ion countertransport and the sodium glucose cotransport. That glucose under normal circumstances is all reabsorbed in the proximal convoluted tubule, and that the kind of diuretic called a carbonic anhydrase inhibitor works in the proximal convoluted tubule by interfering with the production of hydrogen ions by the action of carbonic anhydrase on CO2 and water, and that limits the reabsorption of sodium. So we've made some progress on our little journey, and we've reached the loop of Henle. Now, the loop of Henle is pretty complicated, and I'm going to simplify it a good deal. It has a thick descending part, a thin descending part, a thin ascending part, and a thick ascending part. But I'm mainly going to talk about what happens on the descent and what happens on the ascent, because the loop of Henle has an extremely important role in absorbing water and concentrating urine. And it does that by using a technique that is called, or a mechanism that is called, counter current multiplication. And I want to apologize for the noise. I don't know if it came through or not, but I have a robotic vacuum cleaner that's wandering around the house at the moment, so I just went and turned it off. The other thing that I thought I'd address is that, yes, my hair got cut. My granddaughter cut it, so this is a quarantine haircut. I'm pretty happy with it. I haven't cut my hair in 12 years or something, so it's a big deal. So here we have a diagram that is illustrating this countercurrent multiplier. And I want to maybe go a little bit backwards as we talk about it. And you can see that we have fluid coming in from proximal convoluted tubule, and it's traveling into the loop of Henle, which has a thick descending, a thin descending, a thin ascending, and a thick ascending. If we start on the ascending side of the loop of Henle, there are a ton of those triple transporters. This is a membrane pump that is pushing sodium and chloride and potassium out of the lumen and into the interstitium. And it is working so hard that deep down here at the base of the loop of Henle, the interstitial osmolality is really high, all right, because there's tons of salt getting pumped out here. And what that means is that because there's all this salt, sodium and potassium and chloride, in the interstitium, and a very high osmolarity in the interstitium. When this fluid arrives from the proximal convoluted tubule, water starts to leave it. And as water leaves it, to try to dilute by osmosis from an area of high water concentration to an area of low water concentration, because high solute concentration. As that happens, it's equilibrating osmolality, and the osmolality in the filtrate is now going up dramatically, and lots of water is leaving. As the salt is pumped out into this interstitial tissue in the renal medulla, it raises the osmolarity of the interstitial fluid. That allows water to leave the filtrate by osmosis and enter the interstitial fluid, leaving much more concentrated, saltier, higher osmolarity fluid, that then all that salt, because of the high concentration when it reaches the base of the loop of Henle, all of that salt is pumped out by the sodium potassium chloride triple transporter. Okay, so it's kind of circular, and as I said, sometimes it's a little easier to understand if we start with the pump. But basically the fluid comes in at about 300. It gets highly concentrated as water leaves by osmosis. There aren't a lot of pumps going on this side, except on the basilar surface. Of course, we always have sodium potassium ATPases going. But the main job of the descending loop of Henle is to allow water osmosis. And what this means is that in these tubular interstitial cells, there are pores that allow for the movement of water. Remember that water doesn't move across the lipid membrane unless there are pores, and in this case there are lots of aquaporins. There are pores, and water is able to leave. In the ascending loop of Henle, there aren't aquaporins, so water can't leave, but there are triple transporters, so sodium and potassium and chloride are being pumped into the interstitium. And as that happens, this osmolarity that started at 300 and went up all the way to 1200, very concentrated salty fluid here. As all of that salt is being pushed out, the osmolarity goes way down. So what happens is that at the end of the loop of Henle, we've lost a lot of water, a lot of volume, a lot of salt, and a lot of water. And we actually now have fluid that has a lower osmolarity than plasma and extracellular fluid. And here it enters the next step along the way, which is the distal convoluted tubule. But I want to talk about some other things before we get there. And this is really just a repetition of the picture on the previous slide. The descending loops, the thick and thin portions of the descending loop, are permeable to water. And because of the high level of salt and the high osmolarity in the medulla, water moves through the aquaporins because of the permeability out of the tubule and into the interstitium. As that happens, it increases the osmolality in the lumen. Okay, so that's the descending loop. Once it reaches the bend of the loop of Henle, the osmolality has reached something like 1200, and that's in balance with this very salty interstitial tissue in the medulla. I don't know if any of you eat kidneys, but you may have noticed if you ate kidneys that they're a little saltier than some other meats, and this is why. So that high osmolality at the bend is in balance with the paratubular extracellular fluid. As we begin to ascend in the loop of Henle, the permeability to water goes away. There are no aquaporins. And when we reach the thick ascending loop, this is where there is a ton of active transport, including the triple transporter, which is an ATP using active transporter. So we begin to pump out lots and lots and lots of sodium and potassium and chloride. There are also some channels that allow for potassium to move across cell membranes, and there is some passive reabsorption of calcium and magnesium. As always, on the basilar side or the interstitial side, there is a lot of sodium potassium ATPase. The triple transporter, the sodium potassium 2 chloride transporter, is on the apical side, the luminal side. There's some potassium and chloride cotransport. The intracellular potassium is increased from these pumps, right? Particularly the sodium potassium ATPase. Potassium can leave those interstitial cells through channels down its concentration gradient into the lumen. And that movement of potassium out of the cell through open potassium ion channels creates an electrochemical gradient in the lumen, so that you're negative inside the cell and positive outside the cell, just like when we were talking about the electrical gradient in nerve cells. Because magnesium ions and calcium ions are positively charged and strongly positively charged, they get driven out of the lumen and through a paracellular route between cells. So some magnesium and calcium is reabsorbed in the ascending limb of the loop of Henle. Now, that was all a lot. So I want to just sort of tell you again what's important to know about the loop of Henle, or the thick ascending loop of Henle. It is impermeable to water. It uses active transport with the triple transporter to reabsorb tons of sodium and potassium and chloride. There is reabsorption of calcium and magnesium because of that positive charge in the lumen from the electrochemical gradient created by potassium moving into the lumen. And this is the site of action of our next group of diuretics. And the group of diuretics that act on the loop of Henle are not surprisingly called loop diuretics. This is an illustration, another illustration, because heck, the more pictures the better, right? They're pretty. But it's showing the loop of Henle. It's showing the tubule. We have our tubular cell. We have the apical side and the basilar side. We have a sodium, this is a little weird. We have sodium potassium pump down here, and we have our triple transporter up here. So here's our sodium potassium pump actively pumping sodium out, potassium in. This is a potassium chloride cotransporter. This is the paratubular fluid, right? In the tubular fluid, we have an active transporter that is taking it's actually a co-transporter that is using concentration gradients to drive sodium, to use sodium to drive sodium, potassium, and chloride into the cell, where the sodium leaves by the ATPase and the potassium and chloride leave by cotransport to enter the interstitial fluid. So we end up with less salt here and more salt here, and there's no water moving across this membrane. So as the fluid moves through the loop of Henle, this filtrate that's someday going to be urine, the osmolality increases because on the descending side, water is moving by osmosis out of the lumen into the tissue, and at the base, at the bend, it has reached something like 1200, starting at 300, which is the same as plasma and the same as the filtrate. As it ascends and all of the salt is being pumped out and there is no more water permeability, it goes back down. And by the time it reaches the distal convoluted tubule, it's down to about 100. And so at this point, we've removed much more water and salt. So a lot of reabsorption of water and sodium chloride happens in the loop of Henle. So loop diuretics work in the thick ascending loop by blocking the triple transporter. And examples of loop diuretics include furosemide, which we also call Lasix, and something called ethacrynic acid, and there are a couple of others. Furosemide has other effects as well. In addition to blocking the triple transporter, it tends to be a vasodilator, which increases renal blood flow, which increases glomerular filtration rate. It releases prostaglandins, which are the reason that prostaglandins are the vasodilators, and that enhances the diuretic response. So it actually, in addition to being a diuretic by blocking the triple transporter, keeping sodium from leaving the lumen, and water is going to travel with the sodium, it enhances its own action by releasing prostaglandins, which cause vasodilation and increase glomerular filtration rate and renal blood flow. Furosemide, like many drugs, has potential adverse effects. The mnemonic that is used for furosemide toxicities is ODANG. If you like mnemonics, I could never remember mnemonics myself, but this one actually stuck with me. So ODANG for furosemide toxicities. The first O is ototoxicity. This is a drug that can affect hearing, and it's particularly a problem when it's mixed with other drugs that could be ototoxic. Aspirin is ototoxic. The antibiotic gentamicin is ototoxic. So it's just something to think about. We use a lot of furosemide in older people who may already have hearing impairments, and we want to just at least think about it and try not to hurt them harder than we've already hurt them, or help them more than we hurt them. The next one is something we do tend to think about. Furosemide causes hypokalemia. If the triple transporter is not working, then more potassium is staying in the lumen, and you're peeing out more potassium instead of reabsorbing it, and you may end up having low serum potassium. It is such a potent diuretic that it can cause dehydration, so you have to really monitor your patient and make sure you're not taking off too much fluid. Some people have allergies to furosemide. Some people's kidneys are sensitive and become inflamed as a result of furosemide use. And finally, gout. People on furosemide tend to build up higher levels of uric acid in their blood, not because of the triple transporter mechanism, but because of other mechanisms having to do with concentrating uric acid. If sodium stays in the lumen, water stays in the lumen with it. If we don't have the potassium gradient from pumping all that potassium back into the cell, less of it's leaking out, and so we have less calcium and magnesium reabsorbed. And again, we have this potential for hypokalemia because potassium is staying in the lumen instead of coming back into the cell. There is a medical condition called Barter's syndrome that is a gene mutation for proteins in the thick ascending loop. And as you think about it, what are these transporters? They're proteins in cell membranes. And in Barter's syndrome, the mutation affects the triple transporter. So the triple transporter doesn't work. And that means that the patient with Barter's syndrome is effectively on Lasix all the time without Lasix. So they need to drink more because they pee more. They lose potassium, they lose sodium. Over time, they can become alkalotic, and this has to do with a mechanism further on. In the collecting duct, there's a pump that exchanges potassium for hydrogen ions, and because we don't have the potassium, we can't exchange it for hydrogen ions, or rather, I take that back, because there is so much potassium in the lumen because it made it past the loop of Henle. Let's try that again. The hypokalemia triggers the metabolic acidosis. And the reason that this happens is that there is more potassium in the filtrate, right? The reason you become hypokalemic is you're peeing out your potassium. So there is a mechanism further along in the tubule in a place called the collecting duct that exchanges potassium in the lumen for hydrogen ions in the interstitium. In order to save more potassium, that gets ramped up and you lose more hydrogen ions, and that can cause a metabolic alkalosis. And then finally, you're not pumping chloride out of the lumen, and so you have negative ions in the lumen that hold on to those hydrogen ions in the urine, and so you lose more hydrogen ions in the urine. So you lose sodium, you lose potassium, you lose hydrogen ions, and you lose water. I had a patient with this. It was a young woman. She was a military dependent, and her potassium levels were so low that she had to take something like 10 to 15, probably closer to 15 potassium tablets a day to maintain her potassium in the normal level. Some of you have probably seen potassium tablets. They're big. They're like huge suckers. They're like the biggest vitamin you ever saw. And she just could, and they're a little irritating to the stomach, and they taste sucky. And she just couldn't keep up with taking all of her potassium pills. I mean, I had to prescribe her bottles and bottles of potassium pills. But every time she'd come into the clinic and I'd see her, ask her how she was doing, ask her if she was taking her meds, she'd always say, I'm trying. That, and we'd draw blood. At about 2 in the morning, I'd get a phone call at home from LabCorp in Burlington that her potassium level was something like 2.4, normal being 3.5 to 5, 2.4 being on the edge of death. And I'd have to call her up, get her out of bed, send her to the ED at Womack, where she'd get potassium infusions. Strongly encouraged to take her potassium pills, and sent home till the next cycle. It happened every time I saw her. I liked her a lot. I have rarely been so happy when somebody's husband got transferred because I really didn't want her to die on my watch. So we've made it further along to the part of the tubule called the distal convoluted tubule. Now, this is getting boring, isn't it? The distal convoluted tubule has somewhat different transporters. There's a sodium chloride cotransporter in the lumen. As always, there's the sodium potassium ATPase on the interstitium. We have a sodium calcium counter transporter that is helping us to reabsorb calcium. And this is important because the hormone that we call parathyroid hormone, which is made by the parathyroid glands and that we'll talk about in our endocrine unit, acts in the distal convoluted tubule. It stimulates the production of the pumps, of the transporters, that allow us to reabsorb calcium out of the urine back into the extracellular fluid. And as I think I said early on in the course, calcium has to be maintained within a very narrow window. Homeostasis requires lots of things to be maintained within relatively narrow windows, but calcium has a very narrow window. It because of its role in muscle contraction and in cardiac conduction, when calcium levels are impaired, we can have huge problems. So this parathyroid hormone receptor in the distal convoluted tubule is extremely important for calcium reabsorption and for maintaining normal calcium homeostasis. And then finally, the diuretic group that we call thiazide diuretics, that includes hydrochlorothiazide, work in the distal convoluted tubule. So in the distal convoluted tubule, a number of additional things happen. We have talked a little bit about an exchange of potassium and sodium ions. In the distal convoluted tube, the hormone from the adrenal gland that's called aldosterone, and you may remember aldosterone as one of the components of the renin-angiotensin-aldosterone system that is involved in blood pressure control and volume homeostasis. Aldosterone works here by stimulating additional sodium reabsorption out of the urine back into the interstitial fluid and into the vasculature. So at this point, there's still sodium in the filtrate, which is almost urine, and that sodium is now sort of up for grabs. If it stays in the lumen, it leaves with water, and if it is reabsorbed, it brings water back in, and so it helps to maintain volume homeostasis. In addition, the distal convoluted tubule is a site where hydrogen ions can be secreted and added back into the extracellular compartment. And this is part of how the kidney works to help in acid-base balance. So if sodium ions are low, meaning that the condition is alkalosis, then hydrogen ions are secreted or added to the system by the distal convoluted tubule. And here we're seeing a couple of those mechanisms. This is about sodium reabsorption. So you remember basilar surface, apical surface, sodium, potassium, ATPase, working hard everywhere at the basilar surface. We also have some chloride ion channels. In the lumen, we have an exchange of sodium and potassium ions. So sodium in and potassium out, each down their concentration gradients. There is some movement, paracellular movement of chloride. There is a transporter that uses the concentration gradient of sodium to move chloride through the cell. And so in the distal tubule, the distal convoluted tubule, we have additional sodium reabsorption where we end up with more sodium back in the bloodstream, the extracellular fluid compartment. Now, thiazide diuretics work by shutting down this sodium chloride cotransporter on the luminal side of the distal tubule epithelial cell. And because of that, sodium and chloride stay in the lumen, in the filtrate, holding on to water. And so we lose sodium and water. Just like we had a mnemonic for the adverse drug effects of loop diuretics of Lasix particularly, we have one for thiazides, and it's called hypergluc. Hydrochlorothiazide and other drugs in the thiazide family can cause hyperglycemia. They have a tendency to make diabetes worse. They can contribute to hyperlipidemia. They can contribute to gout by increasing uric acid levels, so hyperuricemia, and they can disturb calcium levels, causing hypercalcemia. All of those things, but they're still widely used and are very good drugs for the treatment of blood pressure. So they do lower blood pressure, largely by helping us lose a little bit of sodium and water. But they are best to avoid in type 2 diabetics. And we've gotten close to the end. We're now in the collecting tubule. And while that sounds like a fairly passive function, collecting tubule, in fact, again, this is an extremely important part of the mechanisms that allow us to either reabsorb salt and water or not reabsorb salt and water. About 5% of water reabsorption occurs in the collecting tubule under normal circumstances, so that's relatively small. But in extreme dehydration, the collecting tubule becomes much more important because it is so sensitive to antidiuretic hormone. When there is no antidiuretic hormone, the cells lining the collecting tubule are completely impermeable to water, meaning that all the water stays within the tubule. When antidiuretic hormone is present, then those cells make aquaporins, water channels, and water can diffuse out of the lumen and water leaves the tubule. Those tubules, if you remember, well, the loop of Henle is in the medulla, but so is the collecting tubule. And the interstitial osmolality is high in the medulla because that's where the loop of Henle is doing its countercurrent multiplication. So the presence or absence of ADH affects the reabsorption of water, and this is water in isolation from sodium through water moving by osmosis through aquaporins out of the tubule into the interstitium in the presence of antidiuretic hormone. In addition, aldosterone works here as well as in the distal convoluted tubule, and aldosterone regulates the number of potassium and sodium channels as well as the potassium sodium ATPase, and therefore its presence affects the reabsorption of sodium. Finally, those ducts have the function of carrying urine from the nephron to the renal pelvis and the ureter. There are parts to the collecting ducts. There's a collecting tubule and medullary connecting ducts in the medulla, and then papillary ducts that empty into a minor calyx into the renal pelvis, into